Welcome to this lecture on PET brain imaging. This presentation will include dementia and memory disorders. Here are the objectives for this presentation. Neurodegenerative diseases are a group of diseases of unknown etiology that affect the central nervous system. There are a variety of neurologic and psychiatric symptoms that come along with it. All of these diseases are incurable, and the most common symptoms are varying types of dementia and depression. Dementia is a progressive loss of cognitive function and functional decline. It's marked by a loss of memory. There are several different types of dementia. The causes in different areas of the brain affected result in varying symptoms and progression. Depression is often a symptom of dementia. Lewy bodies dementia is a specific type of dementia in which the loss of dopamine receptors in the striatum are connected to movement disorders. The most commonly known neurodegenerative diseases are Alzheimer's, Parkinson's, Huntington's disease, and amyotrophic lateral sclerosis, or ALS. Alzheimer's disease has an unknown etiology. One of the main genetic factors is Down syndrome, and it is marked by an atrophy of cortical parts of the frontal and temporal lobes of the brain. The disease affects primarily older people that are greater than 70 years old, and dementia is marked by progressive loss of cognitive function and functional decline, and the loss of memory is the predominant symptom. Alzheimer's is a chronic neurodegenerative disease. It often begins with short-term memory loss, but as the disease advances, patients will have problems with language, disorientation, mood swings, behavioral issues, withdrawal from family and society, loss of body functions, and ultimately these will lead to death. Usually the prognosis from onset to death is about 3 to 9 years. Alzheimer's disease is diagnosed by gross examination of the brain tissue. The brain will appear atrophic. There's narrowing in the gyri and widening of the sulci. The histologic changes include the most prominent things is the cortex, senile plaques, neurofibril tangles, granulovascular degeneration, and deposition of amyloid and neuritic plaques in the wall of the cerebral vessels. Another thing is the deposition of beta amyloid or in the neuritic plaque on the wall of the cerebral vessels. So that beta amyloid plaque accumulation in the brain is a hallmark of Alzheimer's disease. It's not only present in Alzheimer's patients, though, that is important to note. We do see increased deposition and increasing deposition even as the disease progresses in Alzheimer's patients in comparison to normal aging. We also see atrophy of the brain tissue, usually in the temporal and frontal lobes first, and patients will first present with dementia. This progresses until the patient can no longer function, speech becomes a problem, and they will often become bedridden and dependent on care. Beta amyloid plaque is the insoluble fibrous protein aggregates. They clump and interact together to form fibrils. It's believed to play a role in many degenerative diseases, physically disrupts the tissue structure and function. It affects mitochondrial function, poor oxygen, reactive oxygen species, and this leads to apoptosis. It's believed to contribute to arteriosclerosis, Parkinson's disease, diabetes, medullary thyroid cancer, and Alzheimer's disease. This is showing a comparison of a normal brain versus the brain of a patient with Alzheimer's. you'll notice that there is extreme shrinkage in the cerebral cortex, shrinkage of the hippocampus, and then severely enlarged ventricles. In 1991, it was discovered that beta amyloid plaque accumulates in patients with Alzheimer's. A theory emerged suggesting that amyloid beta plaque actually caused Alzheimer's. But in 2009, the theory was updated to mark that beta amyloid complements Alzheimer's disease by suppressing the synaptic function, but it is not the main cause. Elevated amyloid plaques are present in all Alzheimer's patients, but some elderly patients without dementia or Alzheimer's also have elevated plaque deposits. And this is an example of an image of what the beta amyloid plaque looks like. The enzymes will act on the amyloid precursor proteins and cut it into fragments. The beta amyloid fragment is crucial in the formation of those senile plaques that occur within Alzheimer's disease. And this is showing amyloid PET imaging and aging. In the top row, you see that there is increased beta amyloid deposition in patients with Alzheimer's disease. You actually also see the enlarged ventricles there, the shrunk cerebral cortex and hippocampus compared to the normal aging seen below it. You also have normal aging with amyloid plaque, but there isn't that shrinkage in the cerebral cortex and the enlarged ventricles like you see with Alzheimer's patients. So this is an example of how the amyloid agents are used. There will be more amyloid plaque accumulation, and so therefore the brain will take up more of the radiopharmaceutical. Appropriate candidates for amyloid PET imaging include those who complain of persistent or progressive unexplained memory problems or confusion and who demonstrate impairments using standard tests of cognition and memory. Individuals meeting tests for possible Alzheimer's who are unusual in their clinical presentation, and individuals with progressive dementia in atypically early age of onset before the age of 65. Amyloid PET imaging is not appropriate for all patients. Inappropriate candidates include those who are 65 or older and meet the standard definitions and tests for Alzheimer's, since a positive PET scan would provide little added value. Asymptomatic people or those with cognitive complaint but no clinical confirmation of impairment. And it is also inappropriate as a means of determining the severity of dementia when requested solely based on family history or the presence of other risk factors, as a substrate for genetic testing for mutations, or for non-medical reasons such as insurance, legal, or employment decisions. The general sequence of events for the use of amyloid PET, according to new criteria, include the evaluation by a dementia expert to assess the need for diagnostic testing, the referral to a qualified provider of amyloid PET services, performance, interpretation, and reporting of amyloid PET scan according to established standards, incorporation of the PET result into the clinical assessment process, and disclosure of the PET result by the clinician to the patient and caregiver, along with discussion of the result and its management consequences. So indications, it really is to evaluate and assess changes causing irregularities in mental and physical status. Cognitive changes would be general confusion and forgetfulness, inability to do math and recognize familiar things. Behavioral includes personality changes, difficulty with self-care, wandering and getting lost. Mood changes include anger, loneliness, depression, and paranoia. And physical changes include jumbled speech, loss of appetite, or inability to combine muscle movements. It is a similar protocol to FDG imaging, except there is no need to evaluate the blood glucose levels. Pregnancy and breastfeeding are relative contraindications, not absolute. The risk and benefits need outweighed and carefully assessed, and then also follow the facility protocols for radiation safety. An inability to lay still for 30 to 60 minutes is a relative contraindication. You may give the patient sedation to avoid motion artifacts, and any other recent nuclear medicine studies that would interfere with the test. In this case, it's a PET study where the presence of activity is still present in the brain. Medical history includes a description of the symptoms, history of dementia, any other neurologic symptoms, current medications and previous surgeries, and the results of other brain imaging studies such as CT, MRI, other PET studies, or SPECT studies. The patient may eat and take medication as necessary. Make sure that the patient can lie still for the entire scan before giving them the injection. If sedation is used, then it's imperative to make sure that the patient has a driver before you inject them. And because this is beta amyloid, there are no requirements for dark room or quiet surroundings. There are 3 approved tracers: florbetapir, flutmetamol, and florbetaben. They have the same indications on their package inserts, and that is basically to estimate the amyloid plaque density in adults with cognitive impairment. A negative scan means there is sparse to no amyloid plaque. Positive scan indicates the presence of moderate to frequent amyloid plaque, and it may be used as an adjunct to other diagnostic evaluations, but it should not be used on its own. So these are the radiopharmaceuticals with their year of approval and manufacture. Florbeta, Florbetapir is Amyvid, and that is an Eli Lilly agent that was approved in 2012. Flutmetamol is more commonly known as Vizamyl, and that is the GE Healthcare product that was approved in 2013. And then Florbetaben is also called Neuraceq, and that was approved in 2014. It's primarily by Bayer or IBA Molecular. And notice that they are all F18 products, and they're tagged to the beta amyloid plaque, so they're very similar drugs. Indications are for the estimation of beta amyloid plaque density in adults with cognitive impairment who are being evaluated for Alzheimer's disease or other causes of cognitive decline. It does not establish an Alzheimer's diagnosis or other cognitive disorder. It can only be used to assist in diagnosis. The method of localization is protein binding to the amyloid plaque. The normal biodistribution is amyloid plaque deposits in the brain. There are no absolute contraindications, and there is also no additional patient prep. So Amivid is the first one we'll talk about. That's florbetapir. That one has a dose of 10 millicuries IV given as a bolus in 10 milliliters or less. Image the patient for 10 minutes, 30 to 50 minutes after injection, and the patient should be positioned supine with their head restraint or in some form of immobilization to keep their head still. The next one is Vizamyl, also known as flutmetamol. That one has a dose of 5 millicuries and it's given within 40 seconds as a bolus in 10 milliliters or less. And then it is advised to flush it with at least 5 to 15 milliliters of saline. That's to make sure that it does get taken up into the venous system and that it doesn't adhere to the lining or the walls of the angiocath. Images for this one are 20-minute acquisition, and this is 90 minutes after injection. This one also comes with a warning about adverse reactions to Vizamyl or the ingredient polysorbate. The most commonly listed as adverse reaction to all three of these drugs is a headache. False negatives and false image interpretation errors do exist, and the reading physician must complete image interpretation training. So these are the three radiopharmaceuticals. The doses are 10 for flurbetapir, 5 millicuries for flutmetamol, about 8 millicuries for florbetabin, and typically they're all basically injected as a bolus, except the florbetabin specifies that it's a slow bolus, and the flutmetamol says it needs to be injected within 40 seconds. Injection supplies are pretty standard. The florbetabir does suggest that it's less than an inch and a half catheter, and that's to minimize the adherence to the catheter. And that's another reason why it's important to use about 10 to 15 milliliters to flush afterwards. Patient instructions are pretty typical. Patients should hydrate, void before and after injection. Florbetabin also recommends that the patient avoid close contact with young children and pregnant women for 24 hours after the injection. Confirm that the patient has prepped and other instructions are properly followed. Make sure that the patient can lay down on the scanner. The caregiver may be needed to help the patient if they have a lot of cognitive impairment. Obtain the IV access, and the patient could be upright or reclining. That doesn't really matter. Inject the tracer, monitor that flow, make sure that it is injected as a slow flow or as a bolus, or I'm sorry, a slow bolus or a bolus, depending on which drug you're using. Patient can void prior to imaging, and then position the patient supine on the scanner with their arms down by their side. Use a head holder or head straps if necessary. It is recommended to not use a foam headrest, and to use a regular head holder that is for brain imaging, and to use gentle straps to make sure that the patient does not move, and then ensure that there's minimal interaction or movement. For florbetatapir, the standard uptake time is 30 to 50 minutes. Injection or the acquisition scan is 10 minutes. That acquisition scan time may differ based on the scanner that you're using. Some of the newer ones or digital ones, you may not have to scan for as long. The head should be positioned to center the brain with the cerebellum in the field of view, and then reduce that head movement with flexible or gentle restraints. With flutmetamol, the standard uptake time is 60 to 120 minutes. The acquisition time is 10 to 20 minutes. You'll position the patient the same way. They'll be supine with their brain and the cerebellum in the center of the field of view. Flutmetabol does suggest that the patient's head is tilted a little bit, so the anterior commissure posterior commissure plane is at the right angle to the bore axis of the scanner. You can use this with the laser positioners, and then use suitable head restraints. For florbetabin, the uptake time is 45 to 130 minutes, and the acquisition time is 15 to 20 minutes. And that same thing, the patient should be positioned with their brain in the center of the field of view, and reduce head movement with flexible restraints. Camera type is PET or PET CT. PET CT is better for the attenuation correction. Acquisition mode could be 2D or 3D. If 3D mode is used, the images may take less time. If 2D mode is used, you may want to increase the acquisition time to get appropriate counts. It is just one bed position just over the brain, and the time per bed position will not only vary depending on the tracer that's used, but also the scanner that you have. digital versus non-digital, 2D versus 3D. All of those things come into play when determining how much time to take the images for. And then the field of view will be the entire brain. You want to include the cerebellum. And attenuation correction can be done with cesium or germanium source for PET, or if the PET CT acquisition is being done, then you would use the CT for that. Processing techniques will vary greatly depending on the equipment manufacturer and whether you have standalone PET or PET CT or even PET MR. Reconstruction, though, will be transaxial slice with a pixel slice thickness between 2 and 4 millimeters. If you're using standalone PET, you'll use filtered back projection using a Hanning or Shep Logan filter. If you're using iterative reconstruction, it's usually going to be an OSEM, but you'll refer to the manufacturer recommendations for iterations, subsets, and smoothness. And then you will display the images in transverse, coronal, and sagittal projections. These are images from the Fluor Beta Peer package insert. In image A, you see the white matter tracks delineated from the frontal to parietal lobes. In B, you see white matter tracks clearly identified throughout the occipital and temporal areas. In C, you see the scalloped area, scalloped appearance with fingers of the white matter in the frontal cortex. And then in D, you see low levels of tracer in the scalp or skull that should be distinguished from the gray matter uptake by shape and position. And then this is a positive Fluor Beta Peer scan. You see and this is again taken from the package insert. In A, you see white matter tracks that are very difficult to identify from the frontal to the parietal lobe. You also see that there's increased uptake. I know these images are gray, and that makes it a little bit more difficult. They're also small, but you'll notice that there is increased uptake, and that's because there's increased accumulation of the amyloid plaque. So with A, you see that the white matter tracks are difficult to identify. There's a lot of activity in the area. With B, you see the borders of the white matter tracks in the occipital temporal area are lost in some places. With C, you see the gray matter in the medial parietal cortex shows increased uptake. And then D is pointing to low levels of tracer in the scalp or skull. That should be, and they should be distinguished from gray matter uptake by its shape and position. These ones are color scheme, and this is from the Flute Metamol package insert. This is a typical color scheme for looking at amyloid imaging. And this is a transverse slice. The left is a negative study, and on the right is a positive study. More amyloid plaques in the brain mean that there is more amount of tracer in that area. So the hotter the brain appears, the more positive it is. So more tracer means brighter or redder, in this case, areas. These are two sagittal views using Flute Metamol. On the left is a negative patient, and on the right is a positive one. You'll see there's increased activity in the around the corpus callosum and the posterior cingulate. And this is Flute Metamol scan with coronal images. You see on the left a negative study and on the right a positive one. You see a lot of increased uptake in the inferior parietal lobe regions and also in the posterior cinguli. Here are the scan characteristics for Betabin. They're very similar for all of the amyloid agents. For a negative scan, you will see spiky finger-like projections in the lateral temporal and parietal lobes. It will give a starfish appearance in the frontal lobes. and an upside down V structure in the posterior cingulate and precuneus regions. And you'll have a smiley face in the parietal lobes. For a positive scan, you'll see much more uptake and accumulation of the beta amyloid. All the nooks and crannies, pikes and valleys will fill in and become very smooth. The splenium will lose some of its definition. The posterior cingulate will fill in, and that smiley face structure goes away, and the finger-like projections will fill in. These are images from the floor beta bin package insert. A negative scan is seen on the top row, and then a positive scan is seen in the bottom row. Notice that the cerebellum is used as a reference region, and that's one of the reasons it's very important to include the cerebellum in the images. It shows how white to gray matter intensity should appear, and the physicians will look for white and gray matter uptake differentiation on as they're interpreting images. So normal biodistribution will be non-specific white matter uptake with little or no binding in the gray matter. You want to see less plaque, beta amyloid plaque accumulation in the brain, so you want to see that lower amount of uptake. A negative scan will have clear gray and white matter contrast with a clear gap between the cerebral hemispheres. It will usually be visible, wide, and irregular. A positive scan, on the other hand, will have a loss of the gray matter contrast as more of that amyloid plaque is binding into the gray matter. The cerebral cortex does not usually show radiotracer uptake in the majority of the amyloid positive subjects. And then you'll see hot areas or areas where the amyloid plaque is accumulating. A negative scan will have more radioactivity in the gray matter, and a positive scan will have cortical areas that show that loss, but you must have either 2 or more areas with reduced gray matter contrast, or 1 or more area in which the gray matter is intense and clearly exceeds the radioactivity in the adjacent white matter. Over here, you see the normal patient on the left hand and the Alzheimer's patient on the right. Notice that there is a lot more increased activity in the Alzheimer's disease patient. You also see a lot more uptake down here in the posterior parts of the brain as well as the frontal lobe. And again, this is from the package insert. I wanted to show you close up where it uses that kind of quadrant map to look at separate the areas of the brain. And you see that there's a lot more filling in the positive scan. You don't see the ventricles as clearly, and you see a lot more uptake in the gray matter. So this is PET imaging fused with MRI co-registration for florbetaben. The negative histology, you see this is where it talks about that smiley face. It kind of looks like eyes there. But the positive scan, it's much more filled in, a lot more uptake of the amyloid plaque. So PET and PET-CT brain imaging have seen significant advances. The identity and the presence of beta amyloid plaque is a great discovery that enables us to really see how the disease is progressing and how the beta amyloid plaque accumulates in patients with disease. It has led to improved diagnosis and management of neurologic conditions. And to obtain the best possible results, be familiar with the different radio tracers, prep and educate your patients completely, administer the radiopharmaceuticals correctly, know the camera and manufacturer specific protocols and recommendations, and acquire and process the images for accurate interpretation. And now we'll move on to tau imaging. Tau proteins provide support and structure to healthy neurons. As the neuron microtubules become diseased or damaged, the tau proteins will break loose and clump and tangle together. This image on the left is showing a healthy neuron on the top with the stable tau molecules. And on the bottom, you can see how they've disintegrated. They kind of tangle together, and those tau fibers and tau proteins will end up tangling together and clumping. These tau fibers, once they're clumped together, they're really sticky, and they will accumulate or attract that amyloid plaque. These are the brain changes with Alzheimer's disease. This is a healthy brain with the cerebral cortex and the hippocampus. And then with patients with severe Alzheimer's disease, there is a shrinkage of the cortex, the ventricles become enlarged, and the hippocampus will shrink. If you look a little bit closer up, you see that the damaged and dying nerves will kind of splinter and break apart. Those tau proteins will clump together, and then they attract that amyloid plaque formation. Fluorotaucipir is the radiopharmaceutical for imaging tau proteins. The tau is a group of 6 highly soluble protein isoforms. They maintain the stability of microtubules in the axons, and the typical functions of tau include cellular signaling, neuronal development, and the neuroprotection and apoptosis. The use of fluorotaucipir allows for the estimation of density and distribution of the aggregated tau neurofibril tangles in patients with cognitive impairment. The typical dose for fluorotaucipir is 10 millicuries. Method of localization is protein binding. The critical organ is the intestines, and the normal biodistribution, you really should have no increased neocortical activity or show increased neocortical activity isolated to the mesiotemporal, anterior lateral temporal or frontal regions. The top row is a normal image. You see that there really isn't a lot of uptake of tau or fluorotaucipir in the brain. And then the abnormal scan below it, you see that there is a lot of increased uptake of the tau proteins in certain areas of the brain. Indications for tau or Talvid, it's a radiopharmaceutical diagnostic agent that's indicated for PET imaging of the brain to estimate the density and distribution of the aggregated tau neurofibril tangles in adult patients with cognitive impairment who are being evaluated for Alzheimer's disease. It is not indicated for evaluation of patients for chronic traumatic encephalopathy. And there are no specific contraindications. Of course, as with any radiopharmaceutical, if the patient is pregnant or breastfeeding, that's a relative contraindication, and the risks and benefits would need weighed carefully with the patient. The recommended dose is 10 millicuries administered as a bolus in a total volume of 10 milliliters or less. This should be flushed adequately afterwards. Assessment of pregnancy status is recommended in females of reproductive age. You will want to visually inspect the radiopharmaceutical solution prior to administration. Do not use if it contains particulate matter or if it's discolored, and Talvid may be diluted aseptically in normal saline to maximize the dilution by the end user. You really should use it within 4 hours and before it expires. Assay it in a dose calibrator prior to administration and record that dose according to normal regulations and guidelines. And then the post-administration instructions are to make sure that you adequately flush it with normal saline. After injection, the uptake period takes about 80 minutes. You During that time, the patient does not need to be kept in a quiet room. They do not need to be kept quiet, dimly lit room without stimulation. None of that will matter because it's just accumulating in the tau proteins, and it doesn't have anything to do with the glucose metabolism of the brain. So the patient can read, watch TV, whatever, but the uptake period is going to be 80 minutes. When the patient is ready, you'll have them go to the bathroom before you put them on the scanner. You'll have them lay supine on the scanner with the head in the center of the field of view, including the cerebellum. And you want to tape or use flexible head restraints. Gentle restraints may be used to reduce that head movement. And then you will obtain a 20-minute PET image with the patient supine. PET-CT or PET-MR is recommended to decipher the noise and motion. You get a lot better image quality when you have that versus standalone PET scanning. As far as processing the images, you'll want to follow the manufacturer's guidelines. It is very similar to any of the other PET brain studies, but you'll display the images in transverse, sagittal, and coronal planes. Reorient the images as needed to remove any head tilt in the transverse or coronal planes, and use a sagittal slice off the midline to allow the inferior frontal and inferior occipital poles in the horizontal plane. You can select and adjust this color scale to create the visual threshold for positivity. And I do want to point out, if you're doing PET-CT and the patient moves between the attenuated correction CT and the scan, you can do an attenuation scan at the end and repeat that. You can also readjust that in the post-processing or in the processing phase, where you realign the PET images with the CT before you process them and reconstruct them. So make sure, if you're doing PET-CT, that there is alignment between the PET and the CT images to avoid any artifacts. So the goal of the interpretation of the PET study is to identify and locate areas of fluorotaucipir activity in the neocortex that are greater than the background activity, up to 1.65 times greater than the activity that's in the cerebellum. Examine the posterior, lateral, temporal, occipital, parietal, and frontal regions bilaterally. Neocortical activity in either hemisphere contributes to the image interpretation, so it's very carefully to see if there's any additional activity there. Activity in white matter or regions outside the brain do not contribute to the image. And to help identify the posterior lateral temporal area, consider subdividing the temporal lobe into 4 quadrants. And then activity in the anterior and medial temporal lobe does not contribute to the image interpretation. If you're not sure how to divide that temporal lobe into the 4 quadrants, then revisit the interpreter instructions and the package insert that are provided by Talvid Company. And this is showing an example of how that temporal lobe is divided into those 4 quadrants. You look at it in black and white, and then also in color scale. And any areas of increased uptake on the color scale will show up in that color. In this one, they're showing up as green, with the areas of hottest activity being red. Interpretation with Talvid images is based upon the pattern and density of the radioactive signal within the neocortical gray matter. Only uptake of the tracer in the neocortical gray matter region should contribute to interpretation. Off-target binding may be seen in the choroid plexus, the striatum, and the brainstem nuclei. Small foci of non-contiguous tracer uptake may lead to a false positive study. A positive scan shows increased activity in the posterior lateral temporal lobe, occipital, parietal, precutaneous regions with or without frontal activity, and a positive scan supports the presence of widely distributed tau neuropathology in the brain. A negative scan will show no increased activity in the neocortical region or show increased neocortical activity isolated to the mesiotemporal, anterior lateral temporal, or frontal regions. This is from the package insert. This is showing off-target binding in the choroid plexus and the brainstem. Row 1 is an example of a patient with no increased activity. So this is a normal study, but activity is similar in intensity to the cerebellum. Row 2 is an example of a patient with increased isolated activity. Row 3 is the example of a patient with increased neocortical activity isolated to the frontal lobe. And then row 4 is an example of a patient with small isolated foci of non-contiguous and variable uptake in the PLT region. Increased activity in the ALT is shown by the dashed arrows, and this pattern may also be seen in the occipital or parietal lobes. And these are the same patients, just with grayscale and color scale. These are positive scans. A is showing right here in the row 2. A is showing off-target binding in the striatum. That is not considered excess accumulation of tau associated with Alzheimer's disease. That's a normal variant. So row 1 is an example of a patient with increased uptake in the PLT area. Row 2 is an example of patient with increased uptake in the PLT area as well as the occipital regions. And you can see it pretty well there in the color scale. Rows 3 and 4 are examples of a patient with increased neocortical activity in the PLT, occipital lobe, and precutaneous areas. And so this is the same patient in 3 and 4, but you see how extensive that uptake is. And then row 5 is an example of a patient with increased neocortical activity in the medial prefrontal areas, lateral prefrontal, PLT, and occipital and precutaneous regions. So this is very positive in row 5 here. That's extensive uptake of tau protein. I'm going to rotate that to show you the 3D accumulation of tau protein in a patient with Alzheimer's disease. You see that there's pretty extensive uptake there. First, this is the frontal lobe up here. Frontal lobe doesn't have a lot of increased uptake, but there is still some there. So this is a comparison of amyloid versus tau. It is important to know that they are not the same drug. Tau pathology accumulates in parts of the brain different from those where amyloid plaque will form in the early stages of Alzheimer's, and it has been linked closer to cognitive changes. So it is important for patients, if they're being evaluated, to have both. This is a normal study here. Normal normal with amyloid positive, and then Alzheimer's patient that is amyloid and tau positive. You'll notice that it's not necessarily accumulating in the same areas. So beta amyloid plaques and tau neurofibril tangles accumulate, and that is a key to the neuropathological features of Alzheimer's disease. Imaging can benefit patients, increase understanding of disease progression, and assist in the evaluation of treatment efficacy. I want to reiterate that none of these procedures should be used alone for diagnosis of Alzheimer's disease. They are used as adjunct to other things, especially cognitive and functional tests, MRI, CT, and other evaluations for Alzheimer's. That's it. I hope you enjoyed this video. Thank you for watching.